Good evening, everyone. I'm Tico, your chair for this webinar, and I'm the founder of Tico's GP Group, co-founder at myhealthspecialist.com, and a practicing GP in London who is passionate about learning and sharing clinical education, as I know you all are too. Thank you very much to the GPs joining us this evening and to those watching a recording of this webinar in their own time. This evening's event has kindly been brought to us by our group partner, Mayo Clinic Healthcare London, and I'm delighted to introduce Georgina Bishop, Director of Business Development at Mayo, who can tell us more about their service and our knowledgeable speaker this evening. Thank you, Georgina.
Good evening, all. It's great to have so many of you joining us this evening. We are delighted to have you here for the first of our webinars in partnership with My Health Specialist. And it's great for us because we have an opportunity to reach people outside of the London area. So that's very exciting for all of us. Thank you to the My Health Specialist team for organising all of this, especially Tico, Nick and Rasha for their work in just bringing us all together tonight. While I can't take you around the clinic in person today, I would like to show you a bit about our fantastic London facility and what we offer here at Mayo Clinic Healthcare in London. You may well be familiar with the fact that Mayo Clinic has been ranked by Newsweek as the best hospital in the world, and we are ranked #1 in more specialties than any other hospital in the US. Our London facility is conveniently located in the heart of the Harley Street Medical District in Marylebone, which is centrally located and close to a number of tube and railway stations. We've been open for a little over 5 years and offer a range of diagnostic services, including a comprehensive GI service offering consultations and diagnostic endoscopy testing. More of that later. In addition, we also offer expert cardiology consultations and testing, and our beautiful patient-friendly imaging suite offers 3T MRI, CT, X-ray, DEXA and mammography screening. Everything that you would expect of a facility of our quality. I would welcome the opportunity to show you around in person if you would like to contact me separately to arrange for a private tour, and be delighted to introduce you to some of the team. Before I hand over to Dr. Sammy, I would like to encourage you to submit questions at the top of your screen. You will see a Q&A button, so next to the chat symbol, you'll see that there. You will be able to use this to send your questions to Dr. Sammy throughout the presentation, and he will answer those at the end of his presentation, where we have a Q&A session for you. So please do feel free to add any questions that you feel you would like to have answered. But enough about us, let's get on to talking about Dr. Sammy. Dr. Samed Sami has practiced and trained at some of the top medical institutions in the world, including the Mayo Clinic in the US and University College Hospital in London. His research has led to more than 50 peer-reviewed publications, including research papers, review articles, and book chapters, and he has authored a number of national clinical guidelines. Dr. Sammy has earned a number of international and national awards, including the British Society of Gastroenterology Trainees Out of Programme Award, the Cook Medical Marsha Dreyer Award from the American Society for GI Endoscopy, and the American College of Gastroenterology Fellows in Training Award. Without further ado, please welcome Dr. Samed Sami.
Going to unmute now. I guess you can. Am I on now, Caroline?
Yes, you're on deck, Sammy.
Yes, I can see it live. Thanks, Georgina, for the really kind introduction, and good evening, everyone. So, Caroline, I'm assuming everyone can hear me okay, just to make sure. Yes, I'm guessing that's a yes. Right, so I hate doing these remote talks, so prefer face to face. All right, so welcome everyone. I think the talk for tonight will be focused on couple of upper and lower GI conditions, and with a focus on the younger patients. And we're going to be covering heartburn as a symptom, or gastroesophageal reflux disease, and bowel cancer. Slides are not moving. Okay, it's moving now. So the learning objectives will be to talk about upper GI pathology. We decided to talk about gastroesophageal reflux disease, identifying patients with GORD, differentiating, with those patients who come to see us with heartburn, which is a very common symptom, which one of them has actually reflux, which one of them may have other conditions which may also cause heartburn, what recommended tests for reflux, red flags, which I'm sure most of you are aware of. Also touch on the younger patients with reflux, treatment options, and also the role of safety of PPIs. And then we will also talk about bowel cancer, and with a specific focus on the increasing and alarmingly increasing incidence in younger patients, and touch on screening for bowel cancer as well. So as you know, GORD, or gastroesophageal reflux disease, is a condition where acid is produced in the stomach. Here you see on the picture on the left, and when acid goes up into the esophagus, that is what we call reflux. And of course, there are risk factors, and those are important really when you see your patient in clinic. Generally, if I see someone who doesn't tick any of those boxes at all, I always wonder if they do actually have reflux or is something else causing their symptoms. But you're aware of all these risk factors and symptoms, of course, the typical heartburn, regurgitation. Some patients, be mindful, they present with atypical symptoms like cough, bitter taste in the mouth, or sore throat. Why is reflux itself, acid reflux, important? Well, there's a very strong association, which we know about now for decades, between chronic heartburn and reflux and the development of Barrett's and esophageal cancer. So as you can see here, normal esophagus with constant exposure to acid over time, that then turns into Barrett's esophagus, and that slightly increases risk of this esophageal cancer. Red flags, you're all aware of those. I don't need to tell you about red flags in patients with, obviously dysphagia is the main one. But of course, those who are over 55 with non-resolving symptoms. Now, the issue with esophageal cancer is that you really don't want the patient to reach that stage of food getting stuck. And that's the whole one of the main take-home messages of this talk, to be honest, is that you see here, this is the one which has food, which has dysphagia. This is the patient picture on the right. By the time they develop dysphagia, it's unfortunately too late. The 5-year survival in those patients is like 10%. Versus those who we pick up early, who hopefully you see in clinic, you can tell they have acid reflux for a few years, they use Rennies, PPIs frequently. Those are the ones who need to be referred on for an endoscopy. And those are the ones who can be picked up early. You can see this on the picture on the left. This is a small, very early cancer, and this patient has a 90% 5-year survival, which is a huge increase. And that is because of the advances in endoscopic therapy for early cancer. Now we are talking more and more about early detection. So that's, again, another take-home message from today, is that if we detect cancer early, we can cure it, and we can actually cure it via an endoscopic procedure and save the patient even having surgery. So let's talk about a little bit about heartburn. And this is just a case of a patient. I'm going to present two cases. This is a young patient who come to see you with persistent burning in the chest. So he or she will come and say, I've got persistent burning in the chest. You put them on omeprazole 40, you increase it to twice a day. Nothing happens. You refer for endoscopy. Endoscopy is normal. They are fit and well. And now, what do we do next for this patient? I don't think we have a voting mechanism tonight, so I will go ahead and answer that for you. Of course, you don't do surgery on this patient. Adenosine blocker is questionable. I don't think that will help us really get the diagnosis. This is a classic patient where you or haven't responded to PPIs, who you need to refer for further testing, because we need to establish what is the cause of this burning sensation. Is it actually acid or something else? Switch to different PPI. Again, the evidence suggests that is very, very unlikely to work. I would recommend you refer those. This is a patient who needs reflux testing, and we can do this now. Bravo capsule reflux testing at the same time as doing endoscopy. So, you know, 2 tests in 1 visit. So why did this patient that you've seen, and I'm sure a lot of you have come across those patients, you put them on PPIs, they don't get better. Well, this is a fantastic article. It's published some time ago now, but it's still relevant and still up to date, summarizing mechanisms of heartburn symptom in those despite taking PPIs. And as you can see, there are several reasons why patients experience burning in the chest that is not related to actual gastroesophageal reflux. And the commonest by far is what we call functional heartburn or esophageal hypersensitivity. So those are patients who may have normal amount of acid coming up physiologically, but they experience much more symptoms because the esophagus is hypersensitive. This can be linked to psychological comorbidity, stress, genetics, and other factors. And of course, there are other reasons why people don't respond to PPIs. Of course, bioavailability, metabolism, resistance, delayed gastric emptying, a lot of the reasons here you can see. So why do we need reflux testing in those patients? Because we need to differentiate, do they actually have a gastroesophageal reflux disease? Because gastroesophageal reflux disease, or GORD, really is a diagnosis made on physiology testing, not on any other test, versus functional heartburn, which is far more common. The reason we didn't differentiate, of course, the treatment options are different. PPIs may help some people with functional heartburn, but not all of them. Prognosis is different. You know, those are with GORD are the ones who I worry about. Functional heartburn, it doesn't lead to any, you know, serious ill health consequences as such. So someone with ongoing symptoms despite PPI, be very careful, because we know that PPIs are highly effective at suppressing acid. So if their symptoms were caused by acid, then they should respond to PPI, and 93 or up to 99% should respond because they're highly effective at suppressing acid. If they don't respond, then you look for other causes other than GORD, refer them on to a gastroenterologist with special interest in this area. Majority of them usually functional. This is a second patient who is a different demographics, 50-year-old. He does have retrosternal burning after meals. And some acid regurgitation, and he does improve with omeprazole twice a day, but still has a lot of regurgitation issues. There's some improvement. This is, again, what do you think the OGD will show? This is more likely to show some erosive esophagitis. This is a patient who probably has true gastroesophageal reflux disease based on demographics, and there is some response to PPIs at least. And this is a different case scenario here, and that is going to become relevant when we talk about safety of PPIs later on, because the first patient who has probably functional heartburn, when they come to the clinic and ask me, am I safe to take these omeprazole, or long period, I would say probably not, because if they don't have GORD, they're not going to benefit from it, and the harm will be probably more than benefit. This is a patient, however, who does have reflux, responds significantly to PPIs, but still has symptoms. So what do we do? What do we do next? Well, we're going to add an H2 blocker, refer for pH testing. He will need referral at some point, but this guy, in terms of treatment, will need surgery because he has volume reflux that is not going to be fully controlled with PPIs. And volume reflux is a mechanical issue because of hiatus hernia that needs to be fixed. Okay. He will still need pH testing. Some of them we do reflux testing, but if they have significant erosive esophagitis, we don't even do reflux testing because we have the evidence there on endoscopy. So this is a patient, again, who may benefit from surgery. But again, if this patient has very good response to PPIs and they sort out his problem, then the question comes, okay, what do we do? Do we continue PPIs? He's responding very well, perfectly no reflux while he takes omeprazole, say 40 once a day. Do we continue on those and do we continue long-term, etc.? or do we still consider surgery? There are two major landmark randomized controlled trials comparing surgery to PPIs. And this is a very, very important, again, message from the talk today, is that if you see a patient who responds to PPI very well, but they tell you, okay, well, I don't like taking PPIs, I want to have surgery because I don't want to take PPIs, then you really have to tell them and make sure they are aware that, yes, you can have surgery, it's very effective, but it's not a good reason, but not taking not wanting to take PPIs is not a good reason to have surgery, because up to 70% of people will still need PPIs within 5 years of surgery, and 20% needed PPIs for more than 6 months. This is when we do long-term follow-up studies. So they have surgery, it's effective, but after 5-10 years, majority of them may still need some PPIs. So the patients need to be aware of that before they consider surgery. And actually, when we compare head-to-head, PPIs have a similar safety profile to anti-reflux surgery. Okay, so the data is there. There's no increased risk of adverse events, electrolytes, vitamin D, B, folic acid compared to anti-reflux surgery at 5 and 10-year follow-up. So that's another piece of information you need to be aware of when you think about PPIs versus surgery. So what about PPIs safety? I will briefly touch on this area. Of course, it's a very hot topic. I'm sure loads of you get asked by patients. PPIs can cause osteoporosis, dementia, chronic kidney disease, acute injury disease, all of the above. Again, when we look into the data extremely carefully, and believe me, we have analyzed every single study that has been published, we clearly see that, yes, acute kidney injury it has been linked as a causative link to PPIs. But the rest, there is definitely no causative links, no evidence of any causative links to PPIs. And I'll briefly touch on those. So, for example, when patient asks me about, doctor, I've been taking, PPIs, omeprazole, etc., for a year, 2, 3, I don't want to take them long term. I'm worried about hip fracture, osteoporosis. Okay. What do I tell my patient in this situation? Well, I want to check, do they actually need the PPI? And of course, assuming they've done physiology testing, they have reflux demonstrated on physiology testing, they have good response to PPIs, so fine, it is helping them, okay? So I tell this patient, look, I tell them that with regards to osteoporosis and bone fractures, well, the studies which have compared PPI users to non-users, so you take a group of patients who do not take PPIs, okay? Those you will have an incidence of 1.5. I'll tell them for simplicity, I say one patient per 1,000 will have a hip fracture, those who don't take PPIs. Those who take PPIs, 2 patients per 1,000 will have a hip fracture. So the headline you read is that PPIs double the risk of hip fracture, which is technically true, but the absolute risk is still extremely low. So we're talking about 998 patients benefiting from PPIs versus an extra 1 hip fracture. So be aware of the statistics. Hazard ratio and relative risk is important, but absolute risk is what you need to look at, the absolute numbers. And when we exclude smokers from this major landmark study, actually the hazard ratio crosses, the confidence interval crosses 1, so it's not significant. So that's what I tell my patients. There may be a link. The link is not causative. The risk is extremely small. Again, with dementia, that link with dementia has long been shown not to exist. And this is, again, another landmark study published in one of our top gastro journal, one of our major gastroenterology journal, showing that there's no difference in cognitive scores between PPI users and non-PPI users. Okay. Enteric infections, there is something there. I have to say, the data do suggest there is an association, even when you take, big studies, adequately designed studies, prospective, we see that it does increase the odds of getting enteric infections. And the advice to patients I give is that we check that the PPIs are appropriate for the patient and observe hygiene on travel. So the key points from PPI safety is that all the studies showing PPIs causing harm are poor quality, association, not causation studies. Vast majority retrospective, observational, and controlled. Systematic reviews and meta-analysis of those, frankly, inadequate studies. And there's very few prospective, adequately powered studies on this topic. the risk of adverse events remains very low. Okay, so 35% increase in hip fractures is an increase from 1.5 patient per 1,000 to 2 per 1,000. Okay, so that's exceptionally small number. This is a nice summary slide. Again, we will send you these slides after tonight in a PDF. This is a very nice review article, summarizing all the evidence around PPI safety and link between different conditions. And you can see here the kind of the orange square where there has been causal relationship demonstrated. It applies to enteric infections. This is more to do with funding gland polyps in the stomach, which is a benign problem, and then acute kidney injury. Okay, where there is low evidence for causality, we need to be cautious. I always advise my patients who take PPIs long term to have a yearly blood test checking their calcium, vitamin D, magnesium, B12, folic acid, and be careful when I give them antibiotics because of these 3 areas here on the left. As to do with the green squares, the evidence is against that causal relationship. Now, moving to bowel cancer, it's been a big topic, of course, everywhere, mainly because of the increased incidence in young patients. So I thought it would be good to also touch on this area and highlight that, and hopefully that may make a difference to your practice. There's increasing trends in younger patients, and we're going to talk about the theories behind that. We're going to talk about the symptoms and the natural history, diagnosis and treatment options. Perhaps I would say treatment options, maybe in the interest of time, we're not going to be able to cover those in detail, but I would rather want to focus on the natural history of how bowel cancer develops and how am I sharing again? What happened? I can't see my slides. You can see them. I can't see my slides though. Just gonna stop sharing and start again. 1 second. Sorry. Yeah. Okay. Check. Okay. I think I'm back on. Caroline, text me on WhatsApp if there's any problem, but I'm assuming you can see and hear me okay. So in terms of the what we're saying about the bowel cancer is a perfect condition which presents us with a perfect opportunity for screening because of the lag between the development of small polyps and the time it takes for those small polyps to develop into cancer. All right. Computer is a bit slow. Let's see. Okay, I seem to have lost the slides again. What? I can't see them. Okay, I think we're back on. Right. So okay, so bowel cancer. Now, why is it important? Well, it's the 3rd most common cancer, as you may know, and following breast and lung. So it is very common. You know the anatomy. I'm not going to go there. Incidence. there are 42,000 cases. This is data from Cancer Research UK. 16,000 deaths. 53% survive for 10 or more years. So okay, but not a great survival rate. But this is the key thing here. I think this is the key thing from today's talk and where we come in as GPs and gastroenterologists. Is we don't want people to get to that stage. And 54% of bowel cancers are preventable cases. Okay, so that's a huge number. Okay. Causes, again, preventable causes 50%. Those, there's link with eating too little fiber, link with eating too much red meat, and of course obesity, among maybe another one or two environmental factors. Now this is I think one of the main points of the talk. Again, I'll keep hammering this point in terms of the increase of an incidence of bowel cancer among the younger people. Okay, so in the roughly 10 years between 2005 and 2015, there has been a 7.3% increase in the 30 to 39 years, 39-year-olds. I can tell you from my own practice over the last 15 years, the numbers I've seen in the last 5 years are significantly high, I would say, compared, of course, to when I started training. I'm seeing, my youngest patient is a 19-year-old. And I've seen, definitely more than a handful of 20s and 30s and 40s patients with bowel cancer. So there has been about 267 more cases in 2014 versus 2005. Same trend, interestingly, not seen in more than 50 years old. So the increase in the over 50s is much slower compared to the younger. There's an increase in younger age group, and it's possibly been linked to diet, lifestyle, obesity, and there's an interesting research going on around gut bacteria. Again, this is the annual percentage change in incidence of bowel cancer in Europe in the 20 to 39-year-olds, and that is since 1990. So that's 2016, going back to 1990. And this is the annual percentage change, and anything in this area is an increase. This is 3 to 4%, 4 to 5%, 5 to 6% annual increase in bowel cancer in young people in those countries. And you can see the UK, unfortunately, is certainly the worst in Europe in terms of incidence. So we particularly have a big problem. So why is bowel cancer increasing in the younger patients? Well, several theories, but between the early 90s, 2018, number of adults aged 25 to 49 being diagnosed with cancer, again, increased 22% in the UK. Is again kind of presenting different statistics in different ways. Possible reasons, FAP and Lynch syndrome account for some, but very small increase. But we think the sedentary lifestyle, overweight, obesity, smoking and heavy alcohol use, and certainly low fiber, high fat diets, diets high in processed meats are linked to those increases. So reducing bowel cancer risk, we obviously all advise our patients to eat less processed red meat, healthy body weight, high fiber diet. Mediterranean diet is generally the best. Drink less alcohol and avoid smoking. Symptoms. Now, again, this is a situation where, do we want patients to, to get those symptoms? And then unfortunately, the survival, as we said, is going to be low versus early screening, early intervention. So the high risk symptoms in over 60s, certainly, as you know, is rectal bleeding and a change in bowel habits. Okay. So over 60s, rectal bleeding, change in bowel habit, be extremely careful. At any age, obviously constipation, diarrhea, bloating, abdominal pain, and weight loss, they are kind of symptoms, yes, could be symptoms, but they are kind of low risk symptoms, but still need to be kind of taken into consideration. Now, natural history is extremely relevant. I think that's also one of them, I would say, the main take-home points, in addition to the fact that cancer is increasing in young people, and be aware of that, why is it the perfect condition when we can intervene with screening and prevention? Okay, because we all know bowel cancer starts as a polyp. There's as you can see on the picture here, that's how a polyp looks, and some polyps, again, are actually flat. We thought all polyps look this, but we know that there are flat polyps, and those can be potentially more dangerous than protruded polyps. Okay, and that's going to become relevant later when we talk about which screening test to choose. So polyps can come into all shapes, in all shapes and sizes, flat, protruded, etc. And the prevalence of polyps varies with age. So in younger people, less than 55 years old, 14 to 20% prevalence. And the older you get, you can see the number increases to 35, 34, and the 65 to 75, up to 44%. I would say, in my experience, if I do a colonoscopy on someone who's over 60, I would say they will have, 90% of those will have polyps. Okay, these studies, remember, based on people doing colonoscopies, but we don't know the details of the bowel preparation, how clean the bowel is, how long they spent inspecting the bowel, withdrawal techniques, insertion techniques, washing, cleaning, all changing position during the procedure. All these, there are so many factors that come in to the procedure quality that will increase polyp detection rates. Okay, so polyp detection rates can vary significantly between colonoscopists. There is also a link between the size of the polyp and the cancer risks. Okay, so if I see a small polyp, generally less than 15 millimeter, the chance is small, but if we find bigger polyps, then the chances of development of cancer increase with size. So this is how a polyp looks on colonoscopy. This is a very tiny one called diminutive polyp. This is a smaller one, and this is a large polyp. So as I said, if we leave this, the chances of cancer is very high compared to this one, which is smaller. So again, why screening is relevant in the case of bowel cancer? Well, the condition is widely viewed as a tumor with long latency period. So actually, the polyp itself, histologically, it does have low-grade dysplasia, so it's not kind of completely normal. So but there is long period between the existence of that polyp and the development of cancer. So the time between the initiating event and diagnosis could be as long as 10 years. So there's plenty of time for us to intervene and accurately early detect those polyps and screen those patients. And the asymptomatic individuals, as you know, the stool testing, colonoscopy are the commonest ways of screening. It is a condition which is ideal for screening intervention, as I said, and there is data on reducing incidence of mortality with bowel cancer screening. Early diagnosis, again, is a message from today. Intervene early, screen early, then you increase survival rates significantly. 90% 5-year survival rate at the early stage. Okay, but unfortunately, you can see here only 40% of bowel cancer patients are diagnosed at an early stage. Okay, and that's partly due to low screening rates, especially in the UK. Now, who to refer? Again, as you know, and those patients you see in clinic, some of them have no symptoms, okay, and some of them have symptoms. And with symptoms, I'm pretty sure you know what to do. With patients with no symptoms, the latest guidelines, and this is based on the American guidelines, and again, in countries where healthcare is more privatized, like US, a lot of Europe, they start screening age 45. In the NHS, I think it is 55. It may be reducing to 50. To be honest, in my practice, 45 plus, I screen them. But I have more luxury in my private practice to do that. Regardless of what guidelines you want to follow, you follow the guidelines that is appropriate for your job. So I know some of you are private GPs, some of you may be NHS GPs, some of you are mixed, etc. Regardless of the age, the question is, how to screen the patients. Okay, and again, in an ideal situation, and I'm lucky to work in those in one of those places like Mayo Clinic in my private practice. We have the luxury, excuse me, we have the luxury of offering patients 3 options. And that's really what should happen in real life. We offer them fit test, we offer them CT colonography, and we offer them colonoscopy. Okay. What I tell my patients, sorry, let me just see here. Okay. So what I tell my patients is that fit test is a great test, and we explain the pros and cons of that. We explain the pros and cons of CT colonography, the pros and cons of colonoscopy, and then the patient can choose what they want. So fit test, of course, is a great test. It's been shown to reduce mortality from bowel cancer. It detects bowel cancer. It saves lives. And the main advantage of fit test for the patient themselves is that it's non-invasive. They can do it at home. Of course, for the NHS and economically, it is cost-effective as well. Now, in terms of accuracy on an individual patient, I tell my patients that, look, fit test is very good at detecting bowel cancer, but it's not 100% accurate. And depending on which cutoff you use, even at the best cutoffs, it's around, I tell my patients around 90, 95, I give them 95% accurate. Therefore, it can still miss 1 in 20 cancers, okay? But it does pick up the other 19. So that's the kind of main downside. For polyps detection, fit test is not great at all. You know, it depends on the size, location of the polyp. We're talking 50, 60, maybe 70% accuracy. So it can certainly miss polyps, especially smaller ones. Okay. And remember, polyps can grow into cancer, and they can be relevant. That can be relevant. CT colonography is a less invasive than colonoscopy. It's more expensive than fit test for sure. It's almost as expensive as a colonoscopy, in fact, probably, but less invasive, and it's excellent in the right hands at picking up polyps, maybe 5, but certainly 10 millimeter plus. The downside with CT colonography, yes, there is a small dose of radiation, still expensive, and it is not good at picking up flat polyps or sessile serrated lesions. Excuse me. And those are significantly relevant in terms of bowel cancer risk. These are important polyps that we need to pick up and remove, reduce or risk of bowel cancer. So I tell my patient, it doesn't pick up flat polyps, so there is a chance. And of course, if it does show polyp, you still need a colonoscopy to remove that polyp. Colonoscopy, on the other hand, yes, it is certainly more invasive, but in the right hands, it is extremely safe procedure, and that's been demonstrated in a variety of trials and studies. But it does involve taking bowel preparation the day before. Of course, certain patients, if they have comorbidities and other issues, may not be, the risk may be slightly higher. Theoretical risk of perforation causing bleeding with screening colonoscopy. Again, those risks are extremely small. It is an invasive procedure, but I tell the patients the advantage of colonoscopy, of course, is accuracy, because again, in the right hands, the right technique, and the right approach with a clean bowel, we certainly should have a very high accuracy for cancer, certainly, and for significant polyps. And the other advantage of colonoscopy is not just a screening tool. It doesn't tell us what's going on now, but if we see polyps, we can remove them, and that reduces risk of bowel cancer in the future. Okay, so there's a prevention advantage to having a colonoscopy. Okay. And that's what I explain to my patients, essentially. And it would be interesting to see what other people think about that in the Q&A. Feel free to make to put comments there. What about patients with symptoms? I think, you know, most patients with symptoms likely will need a colonoscopy. Certainly, once they reach my clinic, that means they've seen the GP, they've done all sorts of things. So colonoscopy will be likely needed. But of course, also symptom dependent. So what's the take-home message? The take-home message is, please think not all heartburn is gastroesophageal reflux disease or GORD, okay? A lot of people have functional heartburn, other conditions which can give them heartburn. So this needs to be assessed properly by proper history taking, risk factor assessment, response to PPIs, and further testing if needed. Because GORD is important to pick up. It's a risk factor for esophageal cancer. We know that. And to diagnose it, we need reflux testing. And reflux testing nowadays is done relatively non-invasively, not via the 24-hour catheter. We have the option, not always, but we have the option of doing a Bravo capsule monitor, which we've done at the same time as endoscopy with no wires. Please remember that PPIs are highly effective and the benefit outweighs the risk in the right patient. So in those who have GORD, we know that for a fact that they are as effective as surgery. Benefits outweighs the risks. I tell my patients, if you have GORD, you can stop PPIs, you will get erosive esophagitis, your risk of Barrett's increases, your risk of cancer can increase. In fact, in those patients with Barrett's, there is a very good data to suggest that PPIs reduce the risk of cancer progression in patients with Barrett's esophagus. Okay, and that's a big paper published in a major journal several years ago, maybe now. With regards to bowel cancer, it is very common. There are increasing trends in younger patients. Be aware of that. Early diagnosis, again, 90% survival. Be vigilant to younger patients. Please maybe fit test as a minimum and assess them carefully. Thank you very much. Need to stop sharing, maybe.
Thank you very much for that, Dr. Sami. I think it's hard to be able to cover so much into such a short time and to be able to sort of focus our minds on the younger patients as well, because from personal experience, we've had a member of our family who, I know we discussed it before, but he sadly passed away with bowel cancer earlier this year at the age of 47. And he was at a vegetarian diet, and sure, he's had some other risk factors, I know, but it's really sort of focused the mind of the family, a lot of our friends as well, as to the fact that this is in younger patients as well. So we have got some questions, and please, if anyone is out there and you've got a niggle in your head and stuff, please pop a question on, click on the Q&A tab at the top, and we'll try to get through that. I've got a couple myself I'm going to kick off with, and I'll start getting to the others as well. How young is too young for someone to consider a colonoscopy for screening purposes?
Well, screening purposes, that means by definition, those are asymptomatic patients. Especially in my practice at Mayo Clinic, and to be honest, in private practice in London, I know all my colleagues, certainly almost all of them, we follow the American Society guidelines, and those suggest that 45 years or over, you start screening at that age. So, I mean, if you live in the US, once you hit 45, you get an invitation for a colonoscopy. I don't know in terms of the details how often they discuss, a FIT test or CT colonography in terms of options, but certainly I would say 45, you start screening with whatever tool available and whatever tool the patient chooses. There are certain situations, of course, in patients with first-degree relatives with bowel cancer at a young age. Again, there's certain criteria for that. What young age means, 40s sometimes, or certain guidelines also in 50s. Those we may start at age of 40. So if you have a first-degree relative with bowel cancer at a relatively young age, then we need to look at that and think maybe you start at 40.
Okay. And in terms of change in bowel habit, it's a phrase we always read, it's always in the medical literature. What does it actually mean? Is it persistent change? Is it an intermittent change? I mean, everyone has some dodgy food here and there or something, and it doesn't agree with them. How would you distinguish that from a proper change in bowel habit?
Well, I mean, it's a very subjective thing, right? What does it mean? And if you look at the data, it's really highly variable. The definition can vary between different studies. So I think in my kind of pragmatic approach is that if someone, say they go once, so the change could be, well, number one, frequency. Okay, so I always, try and pick patients. So okay, I've been going, usually once a day. Now I'm going 2 times. Of course, I think my connection is. Yeah, I'm back. So frequency change, okay? So maybe 2 to 3 times on a more, of course, not a 1 day kind of change, but it's more consistent. So for a week, 2, 3 weeks, 4 weeks, and of course, the longer it goes on, the more significant it may be. So frequency. Some patients, of course, reduce frequency, so they become, they go every 2, 3 days instead of a daily. So usually I rely on frequency in terms of the bowel habit. But of course, again, some people, there is, in some people, they describe the shape of the stool, sometimes the color. That should also be, these are the other factors which we take into consideration. But really, the frequency is the main one.
A final one from me before I go to the other Q&As. Is there any data suggesting that antibiotic use is related to bowel cancer?
Not that I'm aware of. No. I don't think so. Certainly not solid data for sure. I'm sure there will be some observational maybe data, but not no, not that I'm aware of.
Okay.
Is the
We've
short
got a
answer.
question here. No, that's good.
One thing I
Thank
would
you.
say when it comes to symptoms, one thing I would say also of, and that's it's a crazy how many patients I've seen and have heard of who come in with very non-specific symptoms. Always, non-specific symptoms make me always, a little bit uncomfortable, especially bloating. I've seen all sorts of things. Bloating is very common, of course, which is challenging. But bloating, discomfort, change in bowel habit. I would say be mindful of that.
Brilliant. Thank you. Got a question here. It's a practical one, I think. So, does Mayo take referrals from, I think, private health insurances such as Vitality, etc.?
Yeah, so Mayo has contracts with all private health insurance. We see all private insurance. We deal with all private insurance companies for sure. So that's not a problem. Especially, I think, to be honest, with Vitality specifically. Vitality, I know they have 3 kind of different policies, and Mayo is on all of them. So yeah, some
Yeah, I think
patients
because there is.
Hmm.
Sorry, yeah, I think because it's very complicated, I think, for GPs when you're trying to navigate, you're doing a referral, and then patients are they've got different tiers and stuff. But that's really useful to know, I think.
Yeah. So no, I think especially at least for me personally to get a consultation, I work with all insurance companies. And
Great, thanks. I've got a case here. So a 25-year-old young man booked a telephone consultation today saying that he has some rectal discomfort when sitting on hard chairs and a feeling of needing to open his bowels. It doesn't happen when sitting on soft chairs. He has no other symptoms at all, no altered bowel habit. I've arranged to bring him in to do a rectal examination. This seems a very unusual presentation. I wonder what you think of the sound of this, please.
Yeah, I mean, definitely. I think I fully agree. They need a rectal exam. They need again full history, the usual things. I mean, it seems to me this is more of probably a mechanical thing going on. It could be a hemorrhoid or a pile, internal hemorrhoid. Of course, we have to exclude things like perianal abscess and other things, and of course check. But discomfort doesn't sound like there is any. Yeah, no altered bowel habit and things. So it's unlikely to be a colonic cause for this. It is likely to be an anal or perineal cause. I would check those patients if the symptoms, troublesome. Again, in my practice, I would get an MRI pelvis on those patients if symptoms continue, just to exclude any abscess, inflammation, fistula, all these things which may be not immediately visible on clinical examination. So that's what I would suggest, and also clarify on the examination: is it actually, is the pain in the anal area? Is it in the coccygeal area? There's so to distinguish that maybe from spinal issues, etc. But I think if in doubt, get an MRI pelvis. It's pretty good test and safe. And I think I would explain to patients that, look, it's either going to be a medical problem, a disease type problem that's causing your discomfort, or it's going to be a sensitivity type problem. We all see patients with all sorts of pains and aches, right? Could be rectal. Shoulder pain is the same as, headache. I tell them, we do a scan. If it's clear, then I can tell you there's no kind of, a disease here, and it's likely to be maybe a sensory nerve muscle type issue. So, they perhaps do some exercises, see physio, etc.
And I think that's really useful, actually. And there's also quite a wide range of differentials, not just related to the digestive tract, isn't it? So,
yeah.
I've got another one here. So, in your experience, do you find OD, PPI, or split BD dosing, e.g., 40 milligrams OD or 20 milligrams BD, gives better symptom control?
Very good question. I always start with 40 once a day. That's what kind of all the evidence from trials and treatment efficacies, etc., acid suppression comes from. But if someone is taking 40 once a day and they tell me actually I'm having more symptoms at night, first thing in the morning, I suggest to split to 20 BD to see if it helps. And some people it does, and that's fine. If it doesn't make a difference, then just stick them on 40 once a day.
And a follow-up question sorry, I was going to say is so is anything that people on long-term PPIs can be doing themselves? Should they be on taking probiotics? Is there any certain foods and stuff that they should be having more of, or no?
That's a very good question. There's certainly no data to suggest probiotics make a difference, but actually, because of the interest of time, I think I had a slide on this. Let me see. So let me share that. That's a very good question. I think it's good to discuss it here. Can I share my screen again, or maybe just verbally answer?
I think maybe verbally for now. We can always add it to the PDF pack that we send out.
Sure. We can add it to it. So basically, first of all, we always suggest, and then the evidence suggests, take the lowest minimum effective dose. Okay, so I always tell my patients, well, you're 40 twice a day, well, maybe you don't need it. Even 40 once a day, maybe you don't need it. So cut it down to 20 once a day, for example. If your symptoms are controlled, then that is fine. So minimum effective dose is what we suggest, and the duration, of course, depends on the patient. If they have GORD, chronic symptoms, they may need long term. In terms of the issues around kidney disease, hypomagnesemia, hypocalcemia, B12, folic acid deficiencies, what I would say, I get my patients to have a blood test every year, as I said, to check the levels, especially also the magnesium levels, because there's a link with hypomagnesemia. And then calcium, phosphate, B12, ferritin, and folic acid, and also vitamin D levels. I tell my patients that they need to make sure they're on vitamin D supplements. Of course, everyone should be, but especially those patients, they must be on vitamin D supplementation. And of course, healthy diet, etc. The usual thing: healthy weight, exercise good for bone health. And these kind of things. So really, in terms of taking stuff, vitamin D, yes. I also, again, that's not based on any evidence, tell them to take a multivitamin tablet like Centrum or something, which has got a bit of everything, to cover any possibility of any deficiencies. It's not mandatory, but it's kind of, I just do it in terms of, it's not based on any evidence. Okay. But equally is not harmful to take a multivitamin supplement. So that's really it. And then in terms of enteric infections, of course, hygiene, basic hygiene, especially traveling in tropical areas. Be careful with antibiotics use because of risk with C. diff. So that these are the precautions they need to take rather than what they need to be aware of. Yeah.
Right. I've got a couple more, and I know we've got time. Got a few minutes left. So probably follow on from that one is, do we have to check calcium, magnesium, and vitamin B12 before starting PPI for every patient? You can do a quick one.
Again, yes, of course. Why not? I think it's safer. Again, is there any data or evidence forcing us to do this? No, but I think it's better to do practice safely. I would do definitely in my practice. I mean, most of my patients, they've already had bloods and things, or I would have done their bloods. I would definitely recommend, yes, for sure.
And we're talking just a serum magnesium, just normal when we're doing a blood test on the biochem.
Biochem, you do the renal function. You do the calcium, phosphate, yes, serum magnesium, and vitamin D, and the hematinics, essentially. These are the essential ones.
One last one before we're heading off, and thank you so much for your time this evening. It's been such a pleasure. Is colonoscopy more accurate in diagnosing bowel cancer than CT colonography?
It's a tricky question. I think the answer is yes overall. So it depends on if we are looking at polyps over 10 millimeter in size, then the accuracy is equivalent. It's equivalent to colonoscopy. So certainly 10 millimeter. I don't know if there's data on the 5 millimeter plus. Maybe could be equivalent. I'm not aware of any data on that, but certainly 10 millimeter or more polyps, then there is equivalence. But less than 10 millimeter polyps, certainly less than 5 millimeter polyps or flat polyps, no, colonoscopy is superior.
I'm going to just squeeze in one more because this user's just got it in before the end. So well done, user. How can we wean middle-aged patients off PPI if on long-term, i.e. 20 years with normal OGD, unable to reduce due to severe reflux causing vomiting?
Say again. Sorry, I lost your voice in a bit. Say again.
So how can we wean middle-aged patients off PPI if they're on it long-term, so for 20 years? So middle-aged, with a normal OGD and unable to reduce due to severe reflux.
I'm not sure you need to wean them off. I mean, the OGD is probably normal because they are on PPI. So of course the OGD will be normal. So the central question is that what is the indication for PPIs in that patient? And remember, we don't just rely on symptoms. Has the patient had proper assessment, endoscopy, physiology, reflux monitoring test before initiating PPIs in the first place? Okay. They should have had, everyone on long-term PPIs should have had a specialist assessment of PPIs to see what they actually have excessive esophageal acid exposure of physiology testing. And endoscopy, remember, endoscopy can be normal in up to 70% of people with GORD, with gastroesophageal reflux disease. So endoscopy is not a test to diagnose acid reflux. Endoscopy tells us if there's a hiatus hernia, structural problem, tells us if there is any erosive esophagitis, which is maybe 30% of people with reflux, okay? But it doesn't diagnose reflux. You need physiology testing. And if the patient has excessive esophageal acid exposure on physiology testing, and they respond to PPIs well, then of course we don't wean them off PPIs. There's no need. If the patient hasn't had a proper assessment before starting with those PPIs, and the GP wants to wean them off, then that will be, I think, a referral to a gastroenterologist, because what I would do in my practice, I would wean them off and recheck them after stopping PPIs. Of course, if you wean them off PPIs, as in, reduce the dose, maybe 20 milligram for 2 weeks and 0 for 2 weeks, and you stop PPIs and they are fine, then that's okay. Then you don't need to do much. But I'm assuming the person asking the question means if you stop PPIs or reduce the dose and the symptoms come back, then they need a proper assessment for that. I hope that answers the question.
No, that's a good answer. Thank you so much, and that brings us to the end of the Q&A today. So thank you so much for everyone who's joined us, and everyone who's watching the recording as well. So thank you, Dr. Sami.
Thank you. Thank
you
very much, guys.
We're going to hear from Georgina.
Yeah, I just wanted to say thank you to everybody, actually. So that was most impressive. So Dr. Sami, thank you so much again for your time. I can see the numbers of people that have joined and stayed. So everybody's clearly found it incredibly interesting. So thank you, Dr. Sami. Thank you, the My Health Specialist team, and thank you to all of our attendees across the country to give us some feedback on what you thought. And if you do have any further questions, please scan the QR QR code. And if any of you would like to arrange a private tour of the facility and come meet myself and potentially Dr. Sammy as well, then please do reach out, and we will be delighted to welcome you. And the contact details are on the screen. So it just takes me to say thank you very much to everybody, either watching live or as this is a recording, and we appreciate you taking the time to join us this evening. Thank you. Good night.